I have the pleasure of introducing our next speaker, Dr. Jill Hall. She's a clinical associate professor at the Faculty of Pharmacy at the University of Edmonton and rheumatology pharmacist at the Edmonton Clinic. Dr. Hall is with us today and we'll be discussing medication and arthritis and information that we're all anxious to hear about here. So please, warm welcome for Dr. Hall.
Thank you. So I always feel like I'm a bit of the bad news bears when it comes to discussing pain relief. And I know you've had some great sessions already this morning, and I'll echo some of the sentiments that I at least heard repeated just now. So happy to be here with you. Just curious, how many of you have inflammatory arthritis? Okay, so there's quite a good number of you in the audience. That's most of what I do in my clinical practice, is manage patients with inflammatory arthritis. Most of the talk that I set up for you today relates more, of course, to pain relief, which is what we're talking about today, and will be somewhat applicable to inflammatory arthritis, but especially for osteoarthritis. So I want to talk about the difference between managing inflammatory arthritis and osteoarthritis, and I want to get you ready to engage in discussions with your healthcare providers and talk a little bit about how your pharmacist is an important part of your care team. So we know that there are two main types of arthritis, or that we'll talk about today at least. So osteoarthritis and inflammatory arthritis. The symptoms of these are different, and it's really by clinical signs and symptoms that we are able to tell, in speaking with any individual patient, what type of arthritis you most likely have. So that the amount of morning stiffness that you have, whether your arthritis gets better or worse with movement or with repetitive movement, helps us determine which is which and what pathway to follow. And that's really important because there is more than one kind of approach to management of arthritis. When you have an inflammatory arthritis, we have a number of very effective disease-modifying anti-rheumatic drugs. So these are things like Christine mentioned, methotrexate, sulfasalazine, leflunomide, the biologic drugs, some of the newer small molecule drugs. And we can really treat the root of the problem. So the immune system is actively involved. We know that if we modulate that, we can do a great job of preventing long-term complications and the pain associated with inflammatory arthritis. So I always say if you have an inflammatory arthritis and you're having pain that's related to that inflammatory arthritis, we need to treat that root of the problem and change those DMARD therapies to get you feeling 100% of you. Whereas if the pain is due to osteoarthritis, we don't have any disease-modifying therapies at this point. We're understanding more and more that osteoarthritis is actually an inflammatory, or can be an inflammatory condition, but it's not the same as an inflammatory arthritis. And so we're stuck a little bit with symptom management and trying to get you to be as functional as you can with whatever joint that is that's affected with osteoarthritis. And sometimes it's that people with inflammatory arthritis have an osteoarthritis as well, and we need to kind of tease those out to determine what the best treatment strategy is. So when I talk to patients with inflammatory arthritis, I use the analogy of a tree, which I have here, a beautifully trimmed tree, and I say our disease-modifying drugs are the things that get at the root of the problem to make the tree as healthy as it can be, and most of the therapies I'm going to be talking about today are really trimming the trees and making things look good, so helping to decrease pain, maybe decrease some inflammation, help you be a little bit more functional, but it's really just symptom management, and we're not able to impact at this point the progression of osteoarthritis. So I know you've had a couple of physicians and a physiotherapist speak with you today, and I'm a big believer in this multimodal approach to arthritis pain management. Lots of different drug therapies on this slide, lots of different natural health therapies, exercise therapy, all of those things. The one thing I would add is our DMARD therapies if you do have an inflammatory type of arthritis. I also think, just starting off, it's really important that we talk about what reasonable goals are. And I think, as Christine mentioned, advocating for yourself and making sure that you're engaging your healthcare provider so that they know how you're feeling and what's working for you and what's not working for you is so important. We don't have a miracle cure for arthritis, either type. And we're hopefully getting more and more towards more effective treatments for osteoarthritis. But we know what we have so far really can only change maybe the way that you feel the pain 20 to 30% on a 10-point scale. That's maybe 1, 2, or 3 points difference. So there's nothing out there that I'm aware of that will take you from an 8 to a 0. And so understanding that, having realistic expectations of what you might be able to achieve with a new therapy is really important so that you don't give up on it or be disappointed or feel like nothing that I'm doing is helping. The good part is we know from lots of research that if you have a 2 or a 3-point change on that pain scale, that can lead to a big difference in your function and how you're able to contribute to your family and your life and the things that you want to be doing and need to be doing. So I'm starting off, I'm a pharmacist. I'm starting off talking about non-medication options because I think they're so important to keeping your entire body healthy, your muscles healthy. So very much in line with our Nordic walking talk as well. Weight management is hugely important. We know if you decrease your weight by 5%, that decreases your pain. If you're particularly overweight, 10% even does even better for you. Physical activity, and I have a husband who actually is a physiotherapist and calls himself allergic to exercise. Seems like counterintuitive. But physical activity is so important, and he says he doesn't exercise because he doesn't like any of it. And so finding that activity that you like, that you can socialize within, that you are going to engage in is going to be the most important thing, no matter what it is. If it's aquasize or it's walking or it's going to Tai Chi or yoga or any one of those things, all going to be helpful in terms of strengthening your muscles and keeping your joints better stabilized. Self-management programs are also really important. There's lots of different support groups and people that get together and education programs that you can attend. And I've included the Flourish program here. So, the Arthritis Society offers a lot with respect to health and wellness and those self-management things. So, trying to keep your own mind healthy in the same way as you go through your journey with osteoarthritis or inflammatory arthritis. There's also a number of different psychological therapies which are helpful for different types of chronic pain syndromes, and those may or may not be right for you, but talking with your healthcare practitioner to determine that would be a good idea. I imagine that your physiotherapist also talked about different modalities within physical therapy and things like thermal therapy or the various types of assistive devices and joint protection strategies that you can use and that are also really important so that you can continue to do the things that you need to be doing and want to be doing, but are protecting your joints and not causing yourself any more damage as you do them. So now let's get into some actual medications. So symptom control medications, we think about analgesics or painkillers and anti-inflammatories most commonly. So really important, again, compared to our disease-modifying therapies that we use for inflammatory arthritis, these things are managing our symptoms, but they're not changing that progression of the disease. So depending what type of product it is, you may see some relief within hours. So you think about taking a Tylenol or an ibuprofen or something for a headache. But really, when you have a longer standing pain issue, it's going to take weeks of a trial with a medication to see a benefit. And so I think it's important, and we'll talk more about this, to set sort of goals or timelines for yourself when you try something new. You know, I'm going to think about how I feel now, 2 weeks from now, 4 weeks from now, 6 weeks from now. How am I feeling? Is this working for me? And if it is, great. If it isn't, then we need to have a plan in place to move on to the next thing. Or if it's partially effective, maybe adding something else on. So we always start with acetaminophen because it's been around for a really long time. We know that it's reasonably effective and that it's reasonably safe. And so it decreases pain. It doesn't have any impact on inflammation. It's still considered first line for osteoarthritis, although the most recent evidence that's come out has shown that, compared to an anti-inflammatory drug, it is less effective. The reason why I think it'll still stay in the guidelines as first line is because it is safe compared to anti-inflammatory. So we'll talk about some of the potential risks or contraindications for people using anti-inflammatory medications. So we can use it for hip, knee, hand osteoarthritis. We can use it alone, or we can use it in combination with a topical anti-inflammatory or an oral anti-inflammatory. You may remember a few years back, and I was surprised actually when I looked at this slide again most recently, that this was in 2011, that there was some concern, there was a lot of media hype around chronic toxicity, liver toxicity with acetaminophen. And the FDA actually changed a couple of things about how they're using acetaminophen in the United States. So they noticed two things. One, there was a lot of acetaminophen products that were out on the shelves and available for people to pick up on their own. And people were often using them in combination and not realizing that they were doing so. So using a reasonably high dose for their osteoarthritis, so maybe 2 extra strength Tylenol 3 times a day. And they were also using something for cough and cold and something for their muscle spasm that they had, and all of those different things contained acetaminophen, and they were potentially in the short term or longer term using more acetaminophen than was recommended, and they started noticing a pattern of some liver toxicity and failure. So they did two things. They changed all of their acetaminophen to 325 milligrams, so any product that you get is that strength. And they said the maximum dose that people should take longer term is 3 grams per day. Whereas in Canada, we left things as they were. And we still say that our maximum is 4 grams per day for short-term use. But again, if you're using it for longer term, or if you have any risk factors or previous liver disease, that number is lower. One of those risk factors is regular alcohol use. So anybody who's drinking more than 3 standard drinks per day on a fairly regular basis should probably limit their acetaminophen use to no more than 2 grams, maybe 3 grams per day. So doing that can really help decrease the risk. And outside of that, acetaminophen is considered to be pretty safe for long-term use. So then talking about our non-steroidal anti-inflammatory drugs, or things like ibuprofen and naproxen and whatnot. First talking about the topical ones. So voltaren Emulgel is probably the most popular one that you can get over the counter now in a ready formulation. It's the exact same drug as maybe some of you have used diclofenac in a gel that your pharmacy has made. Same drug, bit of a different formulation, so the strength is a bit different, but basically exactly the same. So these are great for knee and hand osteoarthritis, although hands are a bit tough because we wash our hands so much and we touch our faces and things so much. So I'm always a little bit more cautious with hands, but certainly works well on knees or your elbows and things like that. Hips penetration is a bit more difficult, so there's not a recommendation there, but there's no reason to not try it if that's something that you do want to try for hip pain. So those are great options, and we like to use the topical NSAIDs when, maybe on top of acetaminophen, like I mentioned, or if you have any particular cautions or contraindications to using oral anti-inflammatory drugs. With the oral anti-inflammatories, so we're getting more actual inflammation reduction happening, and as well as pain, useful for hip, knee, hand, all kinds of different osteoarthritis. Again, we're not changing disease outcomes, but this is nice because there's lots of things that are available over the counter. And I know a lot of people were happy when naproxen or Aleve became an over-the-counter product here in Canada. So we consider all of them to be, relatively equal in terms of which one you could potentially use. Sometimes individual patients find one works better than another. So with anti-inflammatories, I say, a 2 to 4 week period before you reassess whether something's actually working really well for you. If one isn't working and you're using it in a reasonable dose according to the side of the packaging, trying another one, you may find that it works better. And there's also some differences in the side effects. So we know, I'll switch slides here, that in the short term they can be associated with nausea or heartburn or some stomach pain. Long term, they can increase your risk of an ulcer or bleeding in your stomach. And some of them are more commonly cause those types of symptoms. So if you're somebody who's prone to that or you've had a previous ulcer, naproxen actually tends to cause more stomach issues than some of the other ones. The other side of things is all anti-inflammatories change the way blood flows through our kidneys and changes the way our blood clots. And so patients who have high blood pressure or sort of on the borderline of high blood pressure may notice that regular use of an anti-inflammatory increases the blood pressure, and we may need to adjust blood pressure medications if an NSAID is something that you need to be taking long term. They also, in changing the way blood flows through the kidney, can contribute if people have impaired kidney function. And so this may be a reason why your doctor or pharmacist actually recommend you don't take an anti-inflammatory. There's also been a lot of talk about anti-inflammatories and cardiovascular risk. This pops in and out of the media every once in a while. We know because they change the way blood clots that they can increase the risk for heart attacks and strokes. And this can happen, within the first week of taking an anti-inflammatory on a regular basis. But this risk is still fairly low. And I always say if you need to be using an anti-inflammatory, then we need to be using an anti-inflammatory. But if it's not working for you, or if you're getting through just a bump in the road where you need to be on something, use it in the lowest dose for the shortest period of time and get off of it if you can. And that will help you decrease that risk. Some of the other ways to reduce some of the side effects, lots of people will be prescribed a stomach protecting drug if they have a history of things irritating their stomach or perhaps an ulcer or something in the past. So using something like an antacid if it's just short term, but something like a proton pump inhibitor, so Nexium, Tecta, Dexilant are some of the current brand names, Losac, Pantalox, some of the older ones. And there is a formulation, ArthroCheck, that includes a stomach protecting drug along with it right away. So some tips for success with anti-inflammatories. Again, lowest effective dose for the shortest period of time, recognizing that when you have osteoarthritis, we don't have a cure for that. And so this might be a longer period of time, and just monitoring and making sure that your kidney function and your blood pressure are doing okay. You're not having any stomach issues as you continue on with therapy. Being aware of other things, so other medications that you're starting or other things that are changing in your health that may require us to reassess how you're using your anti-inflammatory as well. And just remembering to tell everyone that maybe you're using an over-the-counter anti-inflammatory so that we know what your entire medication list is when we're making new decisions for you. So I wanted to talk a little bit more extensively about opioids. Have you talked about opioids today? Yeah? Okay. And what was the basic message? What did you learn? Careful? Okay. Any other words you want to shout out at me? Habit sort of thing? Yeah. Okay. Good. So I think, the pendulum is swinging with opioids. And I think, I almost think about it in the way that we used to think about opioids is kind of the way that we're thinking about medical marijuana now. And I'm hoping that we've learned some lessons from our use of opioid therapy, and we're heading into our journey with medical marijuana with eyes a little bit wider open. And I think more and more we're recognizing the benefit and the big benefit of opioids short term for acute pain, and recognizing that long term their effectiveness doesn't last, and so what we're left with is the risks associated with them without getting the benefits on an ongoing basis. So opioids like acetaminophen are effective in reducing pain and improving function, but they don't have any impact on inflammation. I've got listed there that their use in chronic pain remains controversial, and I think that pendulum is swinging away from their use in chronic pain. I think that we're doing a smarter job of thinking about who to start opioids in, so people who have moderate or severe pain, who have exhausted all other avenues, and really considering the individual patient in front of that prescriber in deciding whether or not to start an opioid therapy. I talked about this early on, but when we're considering opioid therapy, we should be thinking about what is our goal of treatment and having that conversation. What is it that you want to maybe get back to doing? What is your pain level right now, and where did you want it to get to? Where do you think what might make a difference for you? And being very open in having that discussion. Talking about the risks, so I talked about habits or becoming dependent on it. So we know with opioid use we physically become dependent, and that maybe sometimes causes doses to go up over time. We also gain a psychological dependence with them, and that happens not just with opioids but with other medications that we use as well. And there are a number of different adverse effects that we have with opioids. And again, every drug that has an effect is going to have a side effect. So that's not new or something that's different for opioids. When prescribers are starting a new opioid in an individual patient, oftentimes they're making a contract almost. They're saying, okay, yeah, let's talk about your goals. Let's talk about how this is going to go. Let's talk about not only how we're going to start, but if it doesn't work, how are we going to stop? And recognizing that we're not just going to leave these drugs on with mediocre or no benefit, recognizing that risk remains there. If patients are using higher doses, and you've probably seen lots in the media about this too, we're recommending that people have naloxone at home. So if you haven't heard about naloxone, it's an opioid antagonist. So it actually knocks the opioid off of the receptor and protects you from some of the really high-risk adverse effects like decreasing your respiratory drive, so decreasing your respiratory rate, or actually from stopping breathing and having an accidental overdose. So lots in the media right now about people who are misusing street drugs, opioids, and overdosing and dying, but there's a lot of that happening for people who have been prescribed opioid therapy as well. So if somebody is to the point where they're using more than 50 milligrams or equivalent of morphine a day, we're recommending that they have naloxone, know how to use it if they're having some early symptoms, and that their family and friends know how to use it as well to try and decrease that risk. Because there certainly have been a lot of opioid-related deaths recently. Some of the more common nuisance-related opioid side effects include nausea, drowsiness, maybe itchiness, depending which type of opioid you're on. Constipation is certainly a big one, and whenever you start on an opioid therapy, if you ever do, you should also be started on something for bowel routine to try and prevent that constipation rather than trying to treat it later. And then I talked about the respiratory depression, also delirium, and many, many more adverse effects related to opioids. There's also a big role for pharmacists. Obviously, we're the gatekeepers of dispensing for these prescription therapies. And in Alberta, our college, I think, has done a nice job of outlining just a bit more about how pharmacists should be engaging with patients, especially when they're starting a new opioid prescription. So this comes back to, sort of having an agreement with your prescriber, but also with your pharmacist so that we can do what we are trained to do, which is make sure that the medications that you're on are the most effective and are safe for you with respect to moving forward with therapy. So this just outlines what pharmacists are expected to do. And so I'm hoping that more and more as the weeks and the years go by that you're noticing that your pharmacist is engaging you more in an active way to talk about how you're doing with your drug therapies and advocating for my colleagues out in the community that they are starting to take a more active role in helping you get the most from your medications. I'm going to switch gears and talk briefly about duloxetine. So this is a medication that was originally marketed as an antidepressant, but they recognized that it did have some pain modulating effects as well. And so it has an indication in fibromyalgia as well as for knee osteoarthritis. So sometimes this is a nice idea if somebody also has a mood disorder, so depression or anxiety, and we can sort of have two birds with one stone in managing the osteoarthritis pain in this way as well. So the dose of this one is sometimes, sorry. I just want to know what the other name is. Because you asked me, I'm not going to be able to say it. Cymbalta. Little brain. So the dose for this, the dose that's been studied and has evidence to support its use is 60 milligrams per day. And when we get above that, we're generally not seeing any more benefit, and we're seeing only some more side effects. So sometimes people will try and push the dose, and it's always you as an individual to see whether using 90 milligrams instead of 60 milligrams will make a difference. But just be aware that more isn't always better. So just a couple of extra tidbits on additional topical therapies. So some people like using rubs and some people don't. Sometimes it's nice because you actually get a bit of a massage in that area when you're using them and warming it up a little bit. And so there's kind of some extra benefits from using topical therapies in that way. So they're used only when there's a particularly painful point in time, not necessarily every day. Unlike how you would probably use an anti-inflammatory topical on a regular basis. So things like capsaicin, if you use it on a regular basis, can actually help decrease the pain nerves from firing in the same way. And so that can be helpful. Or things like camphor, eucalyptus, menthol, different things like that. They kind of warm up the area, make it feel tingly and somewhat cool as well. And so can almost distract your brain from feeling the pain in that area. So all of those are things that you could use in conjunction with your topical or oral anti-inflammatory, acetaminophen, etc. In terms of intraarticular, so injections actually into the joints, hyaluronic or hyaluronic acid is something that a lot of people have tried. The evidence that's out there right now is a bit conflicting, so depending on what product it is and maybe even who's injecting it, it can be more or less effective. So if this is something that you wanted to try for your osteoarthritis, I would recommend seeing someone who does this quite a lot in their practice so they can choose the right product for you, and they have lots of experience with injecting it. The other piece the other thing that can be injected directly into the joint is steroids. And so this produces more of a localized anti-inflammatory effect. and especially effective for hips and knees. Maybe will be even done under ultrasound to make sure that they get it into that affected area in the best possible way. And that, again, decreases the systemic whole body side effects that you might have from taking a steroid and gets it right into that point of action. Natural health products. So there's lots of things that are out on the market that are there saying, helpful for arthritis. And when they say arthritis, generally they're talking about osteoarthritis and not the inflammatory arthritis. When I talk to patients about natural health products, I have the frame of, is it harmful, potentially? So what do we know about this product? Is there something that interacts with one of the other medications you're taking, or is there a side effect that might not be good for you as an individual? And then, is there any data with respect to effectiveness? So we never know what's going to work for any one individual patient, and so sometimes trying things is a good idea. What I recommend all the time is that you just check with your physician or your pharmacist and say, I want to try this. Is that going to be safe for me? And then again, you think about what you actually want to get from that product. No different than what you would do when you're starting on acetaminophen or an anti-inflammatory. So you might say, and actually write down, I've got left knee pain that's been really bothering me. I want to know if glucosamine and chondroitin or something is going to make a difference. And so I'm going to start it, and I'm going to use the dose that's on the side of the bottle or that's been studied in an actual research study. And then 6 weeks, 12 weeks later, has it made a difference for me? Do I have less pain? Am I able to walk up more stairs before needing to stop and take a break? And if you're seeing that effectiveness, then it's probably safe for you to continue using. If you're not, then I just say save your money. If it hasn't made a difference, don't take it anymore. So there's not a lot that has been actually recommended for people that have arthritis. Even glucosamine and chondroitin, which is probably the most popular thing out there still, is just, maybe works, but the big studies that we've done haven't really shown any clinically important differences. But certainly I've had patients who've said that it has made a difference for them, and they continue to use it. Things that I always recommend, calcium, so trying to get 1,200 milligrams of calcium from your diet. Lots of different foods contain calcium, not just dairy. And vitamin D, especially living in Edmonton, so somewhere between 1,000 and 2,000 units of vitamin D a day is a good idea. In terms of monitoring your therapy, I've talked about this quite a few times already. So thinking about that pain scale, how does my knee feel on a scale of 0 to 10? 10 being I couldn't get out of bed, and 0 is perfect. And thinking about what's a reasonable goal for me, maybe decreasing by 1, 2, or 3 points, and has that enabled me to do more in life? And reassessing that therapy. And again, whether it's a natural health product, an injection of hyaluronic acid, or it's an anti-inflammatory. So my take-home points, be patient with your medications. They take time to work, so we're not expecting, one dose and everything's better. We're talking about weeks and weeks. Make sure that you're speaking with your healthcare practitioner about what the best options are for you. Talk about how your pain is affecting you. Talk about needing to try the next thing and wanting to engage in lots of different multimodal approaches to your pain. There's lots and lots of things that we can try, and sometimes it's frustrating when you have to try multiple things, but often it's actually a combination of things that is most effective. So in my last 24 seconds, I'm going to go over just a little bit. Vaccines is one of the things that I research and that I love to talk about, and it's flu season, so I had to bring you a few things. Influenza vaccine, it's covered in Alberta for everybody over the age of 6 months. It's recommended for everyone. It helps protect not only you, but those around you who might be even at higher risk than you are. And so if you haven't gotten it already, I recommend that you do go out and get it and continue to get it on an annual basis. particularly important for people with inflammatory arthritis who we know are at higher risk for influenza and complications from influenza. We've got a good match with the vaccine this year, and there's some ugly strains that are going around. So good idea. Pneumococcal vaccines. So pneumococcal vaccines are recommended for people at the age of 65 and for people with inflammatory arthritis at any age. And I'll have some more information about them on the next slide. And then herpes zoster vaccine. So we've got a new vaccine on the market. It's much more effective than the old vaccine, and we recommend it for the general population over 60. So that would include all of you with osteoarthritis and people with inflammatory arthritis after the age of 50. So pneumococcal vaccines, there's 2 of them, and both are recommended in particular for people with inflammatory arthritis. So Prevnar is a one-time dose, and then Pneumovax 23 is a one-time dose with a booster 5 years later. It's a bit tricky in terms of timing, but if you're interested in getting them and you haven't had either, you just need to separate them by at least 8 weeks. If you've had the Pneumovax 23 already and you'd like to get the Prevnar 13 to boost your immunity to the pneumococcal bacteria, it has to be at least a year since that vaccine was given. The vaccine that's recommended for people just generally over the age of 65 is the Pneumovax 23, and that booster at 5 years is still recommended as well. Bit of a busier slide for herpes zoster vaccines, just comparing the old one and the new one. So I mentioned that the new one is much more effective. It's also great because it's a killed vaccine, which means we don't need to worry about it with any of our biologic therapies that we're using to treat inflammatory arthritis. So it was effective to reduce shingles and also effective to reduce the post-herpetic neuralgia, or the burning, stinging feeling that sometimes remains after somebody has an episode of shingles. The bad news is it's not covered by public health. It is covered by most private payers, and it's reasonably expensive at $300 for the 2-dose vaccine. So it is an initial dose and then a second dose between 2 and 6 months later. And I'll leave you just with some resources, some things that I find particularly helpful. We have our own website, albertarheumatology.com, and I do have some information on there about natural health products specific to how well they may or may not work in arthritis. So if you want to go on there, there's some great information, and if you are interested in a natural health product that you didn't see on there and you'd like to see it on there, you can send us a message through the website as well.